So our patient's a 75-year-old woman who we've heard about with presenting with abdominal pain over many months, found to have gastric ulcers, systemic symptoms of weight loss, not feeling very well, but an absence of other symptoms that we look for, including headache and jaw pain when we think of giant cell arteritis, no joint pains. She didn't have any rash or bleeding into the skin, which we call palpable purpura. There was no prior history of vasculitis. This is not something that's reoccurrent. And she didn't have any history of clots, either superficial or deep clots in the past, or pregnancy losses. And she had no recent infections or real new medications that had been added. And as it was mentioned, she does have a history of breast cancer that was remote and some osteoporosis. She takes very little medications, and she's not smoking anymore, and she's otherwise quite a healthy lady.
There was the breast cancer history as well, 2003, lymph node negative, but she had had a mastectomy, chemo, had completed 5 years of tamoxifen. The physical exam was non-contributory, including breast examination, and the CT from an oncologic perspective was really non-specific, nothing really contributing in that direction. Looking at the labs, CBC was essentially normal. The ferritin was a bit low. B12 was normal. For completeness sake, really, a mammogram of the right breast was ordered, and to conclude that section, really, nothing was found. So at this point, we were left, and in this case, we had an opportunity to discuss and amongst the oncologists because of how unusual it was. We didn't feel as a group that there was anything malignant in this situation. So then that shifts our hat over to the hematologic perspective. Is this presentation due to a thrombotic process? And to look at the investigations Dr. Kim was able to review, and we saw, first of all, the hypercoagulable workup was negative. So then the question was really raised, is it possible that there's an underlying vasculitis with an associated thrombotic event? Always comes to the forefront, especially as some of these other things get knocked off the list. So how do we make those connections? And historically, we see that various systemic inflammatory diseases, including vasculitis, are associated with both increased risk for venous and arterial thrombosis. And we see it increased in these type of diseases, especially during periods when you have active disease. So how do we go back to the basics in terms of the connection between thrombosis and inflammation? Well, we see that during times when you get vascular injury, you get that exposure of the tissue factor, which acts as the initiator for the extrinsic coagulation pathway, which eventually leads to hemostasis. But as you keep getting more tissue factor expression from the vascular cells during the inflammation or vascular injury, you actually get further process towards that thrombosis. So you have this ongoing cycling that seems to happen, which worsens the patient's presentation. We also have to keep in mind that there are a number of regulators that are important with the balancing between hemostasis and thrombosis, and these are some of them that are listed. For example, thrombomodulin is known to decrease the endothelial cell dysfunction and responsiveness to inflammatory mediators, but is also known to activate protein C. So what does activated protein C do? We see impacts on decreasing thrombin generation, increased fibrinolysis, which is the breaking apart of the fibrin. The inflammatory cytokine levels drop as a result of activated protein C, as well as decreased endothelial cell apoptosis, which is programmed cell death. So we see that this is important. There's a balancing act that happens here in hemostasis and thrombosis. So when we look at the initial question, is there a vasculitic process? Is there a thrombotic event connected to that? Well, it's important to think, well, is there even a connection, or are we just making this up? Well, when we look into the literature, there is a connection. There's roughly, as you can see with the ANCA vasculitides, such as Wegener's or microscopic polyangiitis, a 4.8 to 7.0 per 100-person year incidence. When you see about giant cell and Takayasu arteritis, we're getting up to about a third of patients with a risk for thrombosis. Behçet's is another vasculitic disease, and we see about 5 to 19% for DVTs, and up to about 25-26% for superficial vein thrombosis as well. So thrombosis, when you look at Behçet's, what we see in the literature, once again more common with superficial, but there are unusual sites that can be involved. Cerebral sinuses, hepatic, mesenteric, and intracardiac thrombi have been reported, but once again, most common during active disease. So the key things, not recommended to screen for thrombosis in patients who are asymptomatic when it comes to patients with vasculitis. There's also an unclear role for prophylactic therapies, whether it's an antiplatelet agent or anticoagulation. The other piece is that there's no data on the duration of anticoagulation for VTE in the treatment of patients with vasculitides. So the big thing, though, is that at the end, Dr. Kim was, and we had a bit of a chat on this, in the end, really, if you've got a person who's got active disease and you're treating a vasculitis and they have a thrombosis, then you need to have them on anticoagulation for the period that they've got active disease. So that is a factor that we need to consider. At this point, though, we really didn't have an overwhelming feeling that this was potentially a thrombotic process. But there was still the question, is there a vasculitis at play? And so I'm going to turn it over to Dr. Stein at this point, one of our rheumatologists, well, our rheumatologist. We're hoping that we can find more to join him. He's going to present on the rheumatology perspective.
So I was asked to see this patient to rule out the question, does this patient have a vasculitis? So just to start with, just to give a definition for everyone to understand what vasculitis is, this is a systemic inflammatory disease, and it's an inflammation of blood vessels and causes changes in the walls of all blood vessels, thickening, weakening, narrowing, scarring. And these changes will restrict blood flow, resulting in organ and tissue damage, causing aneurysm formation, hemorrhaging, thrombosis, ischemia. And the major targets of vasculitis are arteries, veins, and predominantly they will affect the joints, skin, kidneys, the blood vessels leading to the heart, small blood vessels in the lungs, within the GI system, central nervous system, and peripheral nerves can all be targets. So when we examine patients, we're looking for these sort of findings that would support a diagnosis of vasculitis. For a large vessel vasculitis, there's limb claudication, there's blood pressure differences, absences of pulses, bruits. Medium vessel vasculitis, we look for ulcers on the skin that aren't healing, skin changes, neuropathy, mononeuritis multiplex, and then small vessel lesions would be cutaneous lesions and splinter hemorrhages in the eyes as well. When we examined her, she was actually very healthy. Her blood pressure was great, pulses were normal. She had no evidence of rash or bruising or bleeding into her skin. There was no peripheral ulcers, only the internal ulcers seen on gastroscopy. No nail hemorrhages. She had no skin findings whatsoever, no neurological findings. These are the types of findings we're looking for: the palpable purpura, the non-healing ulcers, and then your bottom left is what we call livido reticularis. She had none of these findings. So all the investigations that were done, the endoscopy, as you heard of, she had ulcers that were healing, but then new ones that were constantly being formed, reoccurring in the fundal. She had a CAT scan, which did show an occlusion in the two different arteries, celiac, superior mesenteric artery. So when thinking about patients with this sort of presentation, these are the types of other conditions that can mimic vasculitis: certain drugs, which she wasn't on; infections, she didn't seem to have any; malignancy, again, the remote possibility of the remote history of breast cancer, but nothing active, and more rare in terms of other infections, endocarditis, cholesterol emboli, quite rare. She had no evidence for any of these. So in terms of our workup for vasculitis, we do lots and lots of blood work. We do specialized antibodies to see if she has any immune system proteins that could be causing this. Imaging is very important. She had her CAT scan. Biopsy obviously is very critical, and she had biopsy of the ulcer, and none of these did show any evidence of vasculitis. In terms of the workup, the only thing that was positive was that she is anemic and continued to be anemic, but she had normal counts, kidneys, white cells. Her overall protein level was normal. And in a systemic inflammatory disease, we would expect a lot of changes in these blood tests, and these were all normal. All of her antibodies were negative as well. And even inflammatory markers, which in an acute or chronic inflammatory disease, you would expect to be very elevated, these were all normal. So in conclusion, with a patient that has systemic symptoms of weight loss, non-healing ulcers, and she does have an occlusion in one of her arteries, but she had really no other evidence of vasculitis. No other major organs besides the GI were affected, and her blood work was not at all suggestive of an acute or chronic inflammatory or vasculitic process.
I was the attending in the CCU at the time when this lady was in the midst of some of her workup, and originally seen by one of the other cardiologists on our service and sent down for a cardiac investigation. So she was sent down for a cardiac scan to rule out ischemia. So she was sent down to our nuclear cardiology lab, presumably for some to rule out coexisting cardiac ischemia. And we got the call on May the 5th that she developed rapid atrial flutter during the Persantin MIBI study. Sorry, it wasn't a Persantin MIBI, it was a GXT MIBI. So during the exercise portion, she developed rapid atrial flutter and required intravenous metoprolol to be given. And shortly after she converted to a normal sinus rhythm, she had a very long, prolonged pause, which is not terribly unusual. We see this quite frequently. Perfusion scans subsequently were reported as normal, but given the sort of rapidity of her heart rate and the instability of her status at the time, she was sent up to the CCU for further observation. So this is what was actually picked up in our CCU. I'm not sure how well it shows, but when she came up, she had further runs of what appears to be atrial flutter. So you see all these big sawtooth waves. So she has some atrial flutter going at a reasonable rate, and then she spontaneously then converts back to a sinus rhythm. So this is your normal rhythm with a P, QRS, and a T wave. But in between, after she converts, and this was not with medication, she was having episodes like this in the CCU. She gets this long, flat line, and someone's written up here 6.4 seconds. So quite a significant delay, which clearly is abnormal. And she went on to have several more of these episodes over the next 2 or 3 days, where she has, again, and this one was captured on an ECG, so that we have more than just the telemetry strip. Someone was actually doing an ECG at the time, and so she had all these episodes, and then this is a sort of a sinus bradycardia. Clearly there's something going on with her sinus rhythm because it's not regular. It fires off, but it's not coming at a regular interval. There's sort of the difference between the PP interval here is longer than the time between this P and this P. So we call that sick sinus syndrome, going between fast heartbeats, slow heartbeats, and really the sorting station or the sinus node is really dysfunctional in this woman, and she has quite a significant burden of disease that was picked up in the CCU. So she went on to have, the way to treat this essentially is to put in a pacemaker to prevent her from going too slow and becoming symptomatic or having episodes of syncope. And then that allows us then to give her any of the medications that we have at our disposal to control her heart rate, such as a beta blocker. So she was given a beta blocker, which is now safe because she has a pacemaker to prevent the slow heartbeats.
So clearly she had an adventurous course so far in the hospital stay, but I think it was fair to say that it wasn't related to vasculitis or hypercoagulability, and although she had the issues with her rhythm, it was not a cardioembolic source that was causing this. So at this point, we decided to refer her to another tertiary referral hospital to get a vascular opinion. So she was admitted from May the 13th to May the 30th. So she had a conventional mesenteric angiogram, and it showed severe stenosis of the celiac axis and the IMA and the SMA. And during the procedure, she actually even developed near occlusion of the celiac axis. And they had discussions with their group, and the gastroenterology was also involved. They repeated the gastroscopy and colonoscopy. In addition, on the colon, she had some multiple ulcers in the transverse and right colon, and the ulcers, as I discussed previously. So they sent the biopsies for a second opinion to Dr. Riddell, who's actually a renowned GI pathologist, and aside from other multiple explanations they had, but there was marked lamina propria fibrosis and withering pits, and it was quite consistent with chronic ischemia. But at this point, the team felt that there wasn't any more they were going to be able to do from a vascular standpoint, and she was discharged and sent back to Thunder Bay. So at this point, we're searching for another opinion, as she was actually doing quite poorly. So we came upon Dr. Lindsay and Dr. Rochenagel at Toronto General and UHN, and I'll like to introduce Dr. Thomas Lindsay.
So thank you very much, and it's a pleasure to be here today. Sam asked me just to bring a few x-rays about this patient and then to cover a few key points with you all about mesenteric ischemia. Mesenteric ischemia is not the most common thing that we do. It only accounts for about 1% of all vascular operations and vascular surgical admissions. And so what I tried to do was to bring you some salient facts that you could walk away with. So I have no disclosures related to this. So first of all, mesenteric ischemia. The mesenteric circulation actually is generally the celiac axis up here, which gives your splenic and your hepatic. And the hepatic gives the right and left, the common hepatic gives the right and left hepatic branches. There is also the gastroduodenal branch, which gives off the superior pancreatoduodenal. And there's usually a interconnection here between the superior mesenteric and the celiac, and some people call this the arc of Bueller. What you're probably a little more familiar with is the superior mesenteric artery, which does give off the right colonic branch and the middle colic branch, but it gives off all the jejunal and ileal branches which have been truncated here so that you can see the inferior mesenteric artery. And there's an anastomosis, the arc of Rieland here, which is this artery here, which connects the superior mesenteric and the inferior mesenteric artery. This is the left colonic artery ascending to meet the middle colic artery here. And the splenic flexure, where this occurs, is an area that we call a vulnerable point for mesenteric ischemia. Here are the sigmoid arteries, and then there are some superior rectal arteries that come from your internal iliac arteries. So there is a rich collateral network. That's point number one. Point number two is that your intestines at rest take about 20% of your cardiac output, which is actually a fairly high amount, considering your kidneys get about 20% at rest. And then after you eat, blood flow can increase between 100 and 150%, and it does so for not just a few minutes, but for often as long as 3 to 6 hours after you eat. And it's been measured mostly in the superior mesenteric. You don't see as big an increase in flow in the celiac artery. Interestingly, that high fat and high protein content of food produces the most sustained hyperemia because you have to break these components down in your gut and then absorb them. And it's that takes the blood supply. And the blood supply is required, obviously, to maintain the intestinal transport, or you get malabsorption. And if you get malabsorption, one of the key findings is the patients get diarrhea as a general rule. So point number 9. Point number 8, the epidemiology of intestinal ischemia. Unlike the majority of other vascular diseases, which are generally more common in men than women, women suffer more from mesenteric ischemia in between a 3 and a 4 to 1 ratio compared to men. And in fact, there is a declining incidence of mesenteric ischemia as annotated in the United States. Point number 7, the pathophysiology is different in acute and chronic mesenteric ischemia, which are the two main types. So this 75-year-old woman has chronic mesenteric ischemia and atherosclerosis of the proximal arterial arteries, especially the celiac and superior mesenteric, because oftentimes the inferior mesenteric artery is occluded in an atherosclerotic aorta. And it's these atherosclerotic occlusions in the proximal part of the artery, as you saw in this woman's SMA, that's the most common reason for the development of mesenteric ischemia. In acute ischemia, it's arterial embolization, and that accounts for 40 to 50% of the cases that we see where patients are either in atrial fibrillation or they have another reason to have an arterial embolus. And because of the downwards going nature of the SMA, they tend to lodge more in the SMA than they do in the celiac. The celiac comes off a little more almost at 90 degrees. Number 6, the clinical presentation of the two is very, very different. When you see patients that have acute arterial ischemia, they come generally to the emergency department. They have pain out of keeping with peritoneal signs. They're complaining of very severe pain. But you examine their belly, it's benign. The reason it's benign is the bowel doesn't die right away. And when the bowel doesn't die right away, they don't have peritonitis. When the bowel starts to die, then they get peritonitis. With chronic ischemia, they have this postprandial pain with progressive weight loss. There's a definite food fear, and they lose weight as if they have a malignancy. Number 5, the chronic form is frequently confused with malignancy, and the acute form is often confused with drug-seeking behavior because the patients have terrible pain, but they have no physical finding. Diagnostic evaluation for both actually is CT angiograms with contrast, because we can get very good definition of the SMA, celiac, IMA, and all of the arterial supply to the bowel. Other diagnostic modalities, well, in acute ischemia, you may think that laparotomy sounds a little ridiculous, but in fact, sometimes that's the fastest way to make the diagnosis of acute ischemia. And in chronic ischemia, you can use duplex ultrasound in a very specific labs, or of course, MR angiography is another diagnostic modality. Therapy, acute ischemia, it's embolectomy or bypass. Obviously, embolectomy, you've got to do a laparotomy, you've got to find the SMA, and sometimes without a pulse in it, it can be difficult to find in a very thick mesentery, but that's generally what we have to do. And if we don't find an embolus, then we have to construct a bypass, usually from the distal thoracic aorta to the superior mesenteric artery. In chronic ischemia, angioplasty or stenting, as we did in this case, or a surgical bypass. I have to tell you, we don't do many surgical bypasses for this because it's a pretty big operation on a fairly cachectic patient, so that our most common therapy is angioplasty and stenting. And the main reason this disease is associated with significant morbidity and mortality is really the delay in diagnosis. It's really an uncommon diagnosis, and people don't see it very often, and that's the reason why. It takes often a while to get to the right place to get it treated. The problem is with acute ischemia, the bowel does begin to die in 60 to 90 minutes, so the patients will eventually develop peritonitis, but often at that point, sometimes we just have to resect the bowel. And in chronic ischemia, there are many studies that show that the average delay is a mean of 15 months, and this woman had symptoms for several, for 18 months. She changed her diet and she was a vegan. So finally, I would just say that diagnosis awareness is critical, because if you've never heard of the diagnosis, then you'll miss it. CT or MR is key investigation after clinical suspicion, and rapid referral and therapy clearly will improve the outcomes, especially in acute ischemia, but also in chronic ischemia.